already pretty much we said, what? Okay, got it. I'm told that we are being recorded. Okay. Yes, yes. So good evening, everybody, and welcome to another District Dialogues. And I think familiar faces in attendance. So you probably already know we've started a program just about a year ago in February, I believe, and had 8 talks so far, and quite a few of them we ended up talking about issues of food. And I was intrigued in a fairly recent ones. Oh, food as medicine started coming up. And in the meantime, we've been talking about what are the next themes, and health, of course, is very important. So we'll be hearing about inequities in healthcare in our city this time. And thank you to Susan and Sig, who helped to arrange this event. And thank you, our guests. So over to you, Susan.
Yeah, tonight's District Dialogues is going to focus on health equity issues in DC. This will be our first session on this topic. We have reached out to city officials from the Department of Health to invite them to speak in District Dialogues in the coming months. So watch the schedule. There's been a lot said about health inequities in the city, and I wanted to just mention some studies. According to a Georgetown University School of Nursing and Health Studies, a 2020 report authored by Dr. Christopher King, health inequity has become one of the district's most pronounced social ills. It noted, and here's a quote, we could probably insert anything we want to here, but it said, Ward 3 residents, because of their wealth, access to healthcare facilities, and higher education level, will live 16 years longer than those in Ward 8. In 2021, Dr. King, again, was the lead author, and with AARP involvement, was a researcher on a 2020 report titled, A Review of Health and Socioeconomic Disparities Among Older Black Adults in the District of Columbia. There's a theme here. And then earlier this month, the Scholarly Journal of Health Affairs published Race, Place, and Structural Racism, a review of health and history in Washington, D.C. And Dr. King, again, was the primary author in that. Tonight, we are lucky to have 2 speakers who have considerable experience in health matters, who can tell and inform us about the reality of health services available to Blacks. In addition to speaking to the topic, I look forward to having them tell us a bit about themselves and how they came to their current professional efforts. Ambrose Lane Jr. has been working in the community development for years. He's a mayoral appointee to the DC Commission on Health Equity and founder, current chair, and convener of the DC Health Alliance Network. That's DC's largest community-based health advocacy group. Ambrose is recognized as an important voice in advocating for better health care for Blacks in our city, especially those who live in Ward 7 and Ward 8. During COVID, I attended one of his forums on COVID. His impressive guest speakers list included the head of Howard University's medical school and Dr. Fauci. Each of the speakers spoke sensitively to the concerns many had about being vaccinated. Now, putting on my village advocacy hat, I need to thank Ambrose for supporting the initiatives put forth by the Long-Term Care Coalition, in which CHV is an active member. Both Ambrose and Mary Proctor gave testimony this morning, or today sometime, I guess it could have been into the evening, right, on the shortage of home health care workers and certified nursing assistants. And this was an important thing, and this is something we've been working on for years, and welcome Ambrose to that fight. Dr. Valda Crowder, who also goes as Dr. V, is a board certified emergency medicine physician who uniquely blends clinical knowledge with public health and business acumen. Dr. Crowder has worked nationally and developed policy that is presently part of today's Emergency Medical Treatment and Labor Act legislation and Affordable Health Care Act. In addition, she has implemented strategies that have improved the quality of care and community wellness measures. Including her professional background was an appointment to the Clinton administration's presidential task force, where it identified areas critical where there's critical workforce shortages and development of strategies to implement successful solutions to identified shortages. Dr. Crowder, a Cornell University graduate and a University College of Medicine graduate, recognized the importance of merging clinical, business, and public health community expertise, and later completed an MBA completed her MBA from Wharton Business School at the University of Pennsylvania. She serves as the national chair of the Health Committee of Black Women for Positive Change. She has over 30 years of experience as a board certified emergency medicine physician. She has provided medical care in 3 pandemics, COVID, one we're still trying to get out of, HIV, tuberculosis. She's also done gun violence incidents, a mass shooting associated with the U.S. Postal Service in Category 4 Hurricane Maria in 2017. Outside of her medical practice, Dr. Crowder holds webinars to answer the public questions about COVID-19. And I want to say welcome, Ambrose, and welcome, Dr. Crowder.
Thank you.
Turn it over to Ambrose. Do you want to kick it off?
I can certainly kick it off, Susan. And I want to thank the Capitol Hill Village for inviting us to talk about this very, very important issue. As was mentioned, I chair the Health Alliance Network, and I'm an appointee by the mayor to the Commission on Health Equity. I still scratch my head as to my appointment because when I was appointed, I said I'm not going to bite my tongue. So I never, I pretty much speak my mind, and so I scratched my head. You sure you want me to be on the Commission for Health Equity? But it's been a wonderful thing, and I'm very glad for the appointment by the mayor. So let me go back to something that you mentioned about the disparities that exist. The Commission on Health Equity issued a report in early 2019. In that report, when you mentioned about longevity of life between communities, you mentioned between Ward 3 and there's an echo, so I needs to mute.
Okay.
Between
Audience, please mute yourself.
Between
Sorry.
Ward 3 and Ward 8. And it was 16 years. And I just wanted to remind you that that's actually the average. That's actually not the full spectrum. The report did 51 statistical neighborhoods. It measured all of the things, from transportation to housing to employment. And the actual disparity, if you look at neighborhoods, is between Palisades and Anacostia. And the difference in how long one lives is actually 21 years. So 2 people born on the same day, and one in Palisades, one in Anacostia. One in Palisades will live 21 years longer than the one born in Anacostia. And this just exemplifies where we have come to. Now we can pretty much trace almost all of the disparity that exists on basically 2 factors. The first factor is racism in policy. Racism, and then racism has actually become negligence. And so racism is, of course, at the center of how neighborhoods have been constructed, how they've been designed, how the district has been designed, how races have been corralled into one part of the city versus the other part of the city. But even and you would say that that's generally typically done by whites in through the eyes of Jim Crow. But that has not necessarily subsided. As a matter of fact, it's kind of transformed, and it's transformed into a kind of a benign negligence. But the negligence is not simply by those that are white. It is also by those that are in power that are African American or other people of color. There is a negligence that also exists that started out as racism. The second thing that I think has had the major impact is poverty. And of course, poverty is a construct out of racism. And so when you look at those 2 factors, you can almost pinpoint how disparities have developed over the years in the communities that we serve. So for example, the Georgetown community was a majority Black community for a long time. As a matter of fact, Foggy Bottom was a majority Black community for a long time. And through these migrations, these forced migrations, those neighborhoods have completely changed. And now you have had African-American people that are corralled mainly right now into Ward 7 and Ward 8. And the city has gone through periodically these types of forced migrations. And we're actually going through that same type of thing again. But this time there are no other frontiers to be had. And so you have the majority of African Americans that are now living in Ward 7 and 8, but there's not another part of the city that they can be pushed to or forced migration to. And so the city has taken on, in my view, a posture, maybe not written in stone, but certainly a posture of gentrification. In plain simple fact, the Washington Post has reported that DC is the #1 city in the nation in terms of gentrification, which is how economic development forces poorer people out because they can't afford the cost of living that exists. And so these are the factors. And so the communities now where the most African Americans are, you have certain markers. So for example, you have food deserts, you have fewer grocery stores. Ward 7 and Ward 8, which has 160,000 people combined, only has 3 grocery stores. Whereas in Ward 3, you have almost 16 grocery stores. And so these are the types of negligence and economic disparity that exist. And when you study these disparities, these health disparities, this negligence and poverty has a direct impact on health. And so you take any community in the nation, and that includes white communities that have no access to fresh food or no access to grocery stores, you will also find some of the same type of health problems and challenges. And so it's not, those markers are not relegated to just black communities. There are poor white communities in Baltimore. There are poor white communities in Richmond. And so when you have certain markers like few grocery stores, more liquor stores, you have disparities in education in terms of resources that go to schools. You have these things that, and you have a lack of jobs. You have all of these things that are markers of poverty. You will have these health disparities. So let me give you some information about where some of these health disparities exist. In Ward 7 and Ward 8, you have the highest rates of end-stage renal disease, kidney disease, liver disease, cancers, high blood pressure, other chronic diseases. And I'll give you one: asthma. I think Ward 6 is probably the only exception. And so let me give you an example just on diabetes by itself. Ward 7 has a 13.4% diabetes rate. Now, what does that actually mean? When you look at countries around the world and their diabetes rates, if Ward 7 were a country, Ward 7 would have the 7th highest diabetes rate in the Western Hemisphere. Ward 8 has a diabetes rate of 19.1%. And that is actually the highest rate of diabetes in the Western Hemisphere. It is also the 7th highest rate of diabetes in the world. If you look at every country and their diabetes rate, Ward 8, if it were a country, would have the 7th highest in the whole world. And so when you have a lack of economic development, when you have a lack of attention paid to access to food and access to fresh food, then you're going to have this level of disparity. And this level of disparity is not, it's what I call endemic. And so, according to the CDC, there's pandemic, there's epidemic, and then there's endemic. Endemic means that it is pervasive and ongoing. That's what endemic means. And so the chronic disease rates in Ward 7, in Ward 8 are endemic because they are pervasive and they are ongoing. And when you look at the spending, even when you look at the district budget and how the district spends its money, there is very little that is spent trying to solve the problems of chronic disease and the inequities that exist in health and in healthcare. And that's before you get to the quality of healthcare itself. Now, we haven't even talked about the quality of healthcare. So to give you an example of that, African-American women have the highest rates of maternal death in the country. So it is even risky for an African-American woman to have a baby, especially if you are living in Ward 7 and Ward 8. So these are some examples of the disparities that exist. So how do we begin to address these disparities and address these issues? Well, I'm a follower of Dr. Martin Luther King. Dr. Martin Luther King said in 1964, when he accepted the Nobel Peace Prize, he said, "Poverty is nothing new. What is new is that we have the resources to fix it." And I say that we in the District of Columbia have the resources to be able not just to address poverty, but to actually eradicate poverty. And I think that if we apply those resources, DC is actually very resource rich. It's one of the most, when it comes to social services, DC has one of the most robust social service platforms in the whole country. I think they are second only to California, but they're coordination poor. And so part of the issue is better coordination for the programs that exist and getting the word out to communities as to how they can join and engage in some of these social service programs that are there. But the second thing is more important, and that is addressing poverty head on and trying to solve poverty head on. We've made the mistake, and I know that in the 60s, there was what was called the War on Poverty. And it addressed issues of housing and housing instability. It addressed issues of jobs. But Dr. King was very critical of that because he thought that it was piecemeal. But we are following that same playbook even now. And instead of just solving the problem of poverty, we are addressing the separate issues that are contained within poverty. And we have to have a different kind of approach to our communities, to economic development. We have to have a different kind of approach to solving some of these problems. And so I can stop there, but when we talk about trying to solve the equity problem, you cannot do that without solving the poverty problem. And that's where we are. Now, you mentioned earlier about seniors, and someone mentioned about No Senior Hungry. So here's an example of the disconnect. Yes, there are seniors that are on fixed incomes and that go hungry. And that is across the board. That is not relegated to Ward 7 or Ward 8. You find seniors that are living in poverty and have food challenges, even in Ward 3. And we know this to be a fact. But if you're gonna address hunger, why not address zero hunger across the board? Why just for seniors, but not for families? So that again is the disconnect of solving a problem for one group without solving the whole problem. There are more families that are in hunger than there are seniors that are in hunger. That doesn't mean that we shouldn't support that program. It's a good program, it's a good bill, but it doesn't solve the problem of hunger. And I'll tie hunger to something else that we all are aware of. I'll tie hunger directly to criminal justice and public safety. The studies show that any child that grows up in hunger is 3 times more likely to commit an act of violence as an adult. And when you have that direct tie from hunger, which is a result of poverty, to public safety and crime, then you can see how it is tied together, and it's tied together in some kind of knot. I didn't serve in the Navy. I don't want to say what kind of knot it was, but it's tied together in a knot, and we have to try to untie that knot to understand where it is that we need to go and how we need to proceed in terms of addressing these issues of equity.
Thank you, Ambrose. And we're gonna let Dr. V talk, and then we'll come back and have some Q&A and discussion. Dr. V?
Sure. So I'm going to actually share a couple of things that I think are really important. And a couple of things are that when we look at disparities in healthcare cannot be solved without everyone having health insurance, right? And once everyone has health insurance, you will still have disparities in healthcare. They just will not be as large. So they've taken studies and they look at insurance status, education, economics, right? And if you take, there's a health disparity for someone who's African American and lives in Palisades and someone who's white and lives in Palisades, right? So when you actually equate for economics, it's less of a disparity than you might have from Palisades to Anacostia, but you still have a disparity. So, you know, I started looking at historically, how did we wind up as being one of the only industrialized countries not to have healthcare for everyone, right? And so when I was at Wharton, I was taught by a professor who was one of the authors of the Social Security bill. And you know how Social Security has Part A, Part B, all the various different parts. So there was supposed to be a part in the Social Security bill that was going to be health insurance for everyone. And what happened was the Vietnam War broke out. And we often hear in America that we do not have the money or the capability or the resources to actually insure everyone. We spent $168 billion with a B on the Vietnam War, which is $1 trillion in today's money, right? So one thing that I would encourage people, you know, is to actually, you know, whenever having a conversation about equity, is to really, why are we not insuring everyone? Massachusetts and Hawaii both require employers, and I think Hawaii may have a, you know, you have to work at least 20 hours or 25 hours, but it doesn't matter. If you work at McDonald's, you get health insurance, right? The other thing that is important is that even when you look at insurance, private insurance is not the same as Medicare, is not the same as HMO, is not the same as Medicaid, right? And that's because of when you look at the reimbursement rates. So sometimes you can have insurance that's actually almost worthless, right? So before I moved to DC, I actually worked in Cooper Hospital in Camden, New Jersey. Cooper Hospital was about a third Hispanic. It was about a third African American, and about a third of our patients had a phone number, which was 999-9999, which means they didn't have a phone, right? This was when payphones still existed on the streets. So if you had chest pain, you'd walk out to the payphone, you'd call 911, and you'd say, I'm at the payphone on the corner of Ross and 3rd Street. And the ambulance would pick you up from that payphone, right? So this is kind of like what it looked like before, you know, everyone sort of had cell phones. Now, I always tell people, I give people a moment, pick a number when I ask you this question. I was working there as an emergency medicine physician. As you know, there's always a hospital side of the bill and a physician side of the bill, right? So we would see a patient, we had a flat rate if we saw a patient that we got from the state of New Jersey in Medicaid. And I pick a number and guess what that flat amount was. Everybody pick a number. It was $9. $9, right? So, you know, a lot of physicians are a little wary, and sometimes hospitals are sort of wary about talking about lower reimbursement rates because they think it's kind of, you know, self, you know, like maybe they're promoting themselves. But at the end of the day, you're not going to have any physician office that is going to be available for you during the day for sick calls or in the evenings if you actually are paying $9. Right now, we took $9 because we're the emergency department and we're seeing everybody. Right, we have an obligation to see everybody. But what that means is you've now training a whole population to come to the emergency department when they have a sore throat, to come to the emergency department when their kid has a cough or a fever or whatever it may happen to be. Right. So the whole structure of our system, when we talk about disparities in healthcare, there's disparities in insurance, right? There's disparities in being uninsured. We often pound our chest and say, oh, we have one of the best healthcare systems in the world. And I always remind people, no, we don't. The World Health Organization has determined who has the best healthcare system in the world, and it's France. And France actually insures all of its population. The other thing that I would say about disparities is a lot of times, and I want to thank Ambrose for bringing up the whole thing around racism, but people really have a hard time understanding, like, how does racism involved in healthcare, right? So I like to share some very, very concrete examples, okay? And it's not just racism. It could be racism, it's sexism sometimes it's anti-LGBTQ, right? So I'll give you a couple examples from my own experience, right? When HIV started and it primarily affected gay men, there wasn't much interest in it, right? Then it started affecting the Black community, not much interest, right? Then what happened was, and I don't know if everybody remembers, but Oprah interviewed a white child that was about 9 years old that had gotten HIV through a blood transfusion. Around that same time, Arthur Ashe, American hero in tennis, became positive for HIV. Suddenly there was interest in HIV, right? Another example, crack, cocaine, that is an illegal substance and it was treated as a crime. Now that we have a lot of white America addicted to opioids, this is an opioid disorder, right? You even have, in the judicial system, you have criminal diversion procedures now where someone will not go to jail and will actually instead go to treatment and go get free treatment. So these are the sorts of things, these are sorts of constructs of how we actually, and it's some of it is unconscious, some of it is unconscious bias, but how we sort of embed these disparities and racism in our healthcare system. So I'll stop there. I just wanted to sort of give just a quick overview and some things for people to kind of think of. Why do we have our system like this? We want to have CNAs that can take care of us. We want to have the people at the grocery store, people who can help us clean our house, but they have no insurance, right? So we've seen even during COVID where these folks were not valued, right? And I agree with Ambrose as well. It's not just minority, it's anybody impoverished is expendable. And that's the way it feels to me, like, as a country, we've decided that they're expendable. And that's something that I'm against. And one of the reasons why I went into emergency medicine was I see everybody. Doesn't matter if you have your deductible or don't have your deductible, or it doesn't matter. I'm an hourly worker. So, that's one of the reasons why I personally went into emergency medicine, because I wanted to take the economics out of my conversation for myself. Do you know what I mean? And so, so that's one of the reasons why I went into it. So yeah, let's open it up for discussion.
Yeah, people can put questions in the chat, and Mary Bloodworth is going to keep track of it. And she says she's going to help me figure out the raised hands for questions.
Okay.
But I'm going to kick it off. Thank you for the talk about the insurance disparity. Of all the disparities that we've been looking at, and I've been collecting things, insurance hadn't hit me. Part of it is the fact that I guess I'm becoming more and more aware of how DC pays insurance. And this is on the Medicaid side. And I probably don't understand the Medicaid thing thoroughly, but I think a lot of our people, or at least we think, that low-income people can have access to Medicaid. And Ambrose might be able to tell you that the statistics are the people who are not covered by Medicaid.
Well, if you remember, even on this morning's hearing, Susan, there were 4 people from La Clínica Puebla, and 2 of them were patients, and they talked about how through the Alliance healthcare system, they lost their healthcare. They were just terminated for no reason. There was no written reason given. They have been struggling to try to get back, and part of that reason is because they have to reapply every 6 months.
Oh.
Can you imagine if you had to reapply for your insurance every 6 months?
Yeah.
But they are compelled, they have to by law, and the mayor can actually change this right now. They are compelled to reapply every 6 months. And one was telling the story of how she was pregnant, had the baby, and had some complications. And after she had the surgery, after the complications, she got a letter saying that her insurance was terminated. And she's still trying and struggling to get her insurance back, and how her daughter had recommended that she was having migraines, and her daughter recommended that she see a neurologist, and she can't see a neurologist. The surgery that they had, they sent her an actual bill for it. This is so there are so many layers when we talk about insurance. So we're not just talking about access to insurance. We're also talking about the quality of insurance. We're talking about what people have to go through to maintain their insurance. All of these things present barriers. And unfortunately, there are more barriers that are presented to people of color.
We understand that the Medicaid operation in DC is the largest of all the government agencies. This Department of Healthcare Finance spends more money than any other agency, and 70% of what they spent comes from the feds. So it's huge. But to hear what you just said in terms of bureaucratic barriers is disturbing. And because I thought that maybe we had crossed the hurdle of low income insurance. Not at all. That's what I'm hearing.
That's before we get to other barriers, such as barriers of transportation and proximity to a person's home.
So can I add something to that too? And I would challenge everybody to do this.
Whoops.
Sorry, I accidentally muted myself. The next time you go to your physician, the physician that you see, ask him if he takes Medicaid. I can guarantee you that most of us on this call, if we asked our physician if they take Medicaid, our primary care physician, they're going to say no. And all you have to do is ask them why, right? And if you want to even look into it a little bit more, ask their office manager why. But the other way you can see it is hospitals and physician offices are closing in Ward 7 and 8, right? Because it is not profitable to run a business over there with Medicaid, with a high percentage of Medicaid, which is low reimbursement, and usually also comes with the amount of paperwork that we had to do to get the $9 was incredible. Right. So I just, I think that, there needs to be some legislation around everyone getting insurance. I tell people, you want to solve this quickly. I tell everybody needs to say, we want the same insurance that the congressman had. The best insurance in the country, better than our own, anyone here on this call, the best insurance is the insurance that the congressman had. So while they're voting no to us, they are actually enjoying the best insurance that there is in the US. So.
Yeah. Well, you just mentioned something about doctors and medical facilities closing in Ward 7 and Ward 8. And we know that there's a new hospital being built over there. And then the other existing hospital, which has got a terrible reputation from what I read in the paper, it will be closing. But there's other facilities, and I just kind of made up a list of how I get my medical care. And there's my primary care doctor, and I go to urgent care. I've been to CVS Minute Clinic, and I'm not sure how many other people have been there. That worked really well. And then emergency rooms. And it used to be that there was a doctor on the corner with his sign out. Now we have to go to a big corporate, MedStar or Johns Hopkins or GW, that type of thing. And I'm wondering what's available over in Ward 7 and Ward 8 for people? Is there an urgent care?
So the new hospital and the contract with George Washington University provides that in addition to the new level 3 trauma center, they will construct 2 urgent care centers, one in Ward 7 and one in Ward 8.
Okay.
So that does represent some progress, but let me also just make sure that it's understood that the reason that the new hospital will be able to be sustainable in the short term is that they raised the reimbursement rates for the hospital.
Right.
If the hospital was using the same reimbursement rates as it had before now, it would not survive, because that's why United Medical Center found it difficult to survive. They couldn't make a profit because 90% of their patients were Medicaid patients. And
right. So let's just say this. So that means had they raised the reimbursement rates earlier, you may not have disrupted care, by
Correct.
actually losing these two facilities,
Correct.
right? Right. And so because the hospital's not built yet, I don't know, when is it supposed to open, Ambrose?
2024, they just had the
Yeah.
groundbreaking last week.
Yeah. So you have a disruption of care when they could have increased the reimbursement rate, but it's a philosophy in government where they say, oh, we can lower it. The doctors and the hospitals don't want to complain, then they just go out of business. Right. And I tell people all the time, I says, you have to decide, that you have reached an unsustainable rate. There's no place else to cut, right? Because then you're cutting and it doesn't really make sense anymore for people to actually provide the
But
care.
those are political decisions that are made in political rooms that are skewed by the lens, again, of racism and negligence. That if they had raised the rates, United Medical Center could have survived. When they closed the maternity ward, the estimate to completely redo the maternity ward was about between, I would say, $20 and $25 million. That is small potatoes money in a $17.5 billion budget.
Yeah.
So as my friend Ed Lazier has always said, budgets are moral documents.
Yeah.
Got it. How many, if a person is living in Ward 7, where do you go for your health care?
Well, all we really have in Ward 7 are FQHCs.
Wait, does everybody know what those are?
Federally qualified health centers. Okay, so Unity Healthcare is an FQHC, for example. And there are several Unity Healthcare health centers in Ward 7. And so that's where people will go. They do have some doctors that are there, but then you have very few that are in private practice in Ward 7. And let me just say this, part of the reason why you have fewer private practice doctors east of the river in general is because of the high insurance rates. It's very difficult to get the insurance rates. If you are a single doctor, you actually almost have to be part of a group. So for example, George Washington University has MFA, the Medical Faculty Associates, and all the physicians join MFA, and MFA purchases insurance in bulk for all of their physicians. And so you don't have that for single practitioners in Ward 7 and Ward 8. They have to buy individual insurance, and it is sky high. So one of the things that my organization has been pushing is the need for tort reform, insurance reform, so that more doctors can individually locate east of the river.
I have a question. This is Miss Juanita. And I want to say good evening to everybody. I have Medicaid, I had full Medicaid until February 1st. I had set a dentist appointment and ready to go to the dentist, this month. I had to change it because they didn't take the health insurance that I had. I didn't change my health insurance, the government changed it. I'm 67 years old. And why did they change my health care? Why did they change my services without me even signing a document stating that it's supposed to have happened? They kept calling my phone and I kept ignoring their phone call because I thought it was a prank. But with that said, the Unity Healthcare services, it's not the best services in the city. I would not call Unity Healthcare services because you cannot get a person on the line to talk to them. And when you call them, you got to go through so much red tape to try to get a doctor or get someone to make an appointment. Navigating the system with them is so difficult. So now I was forced to keep everything, try to keep all my eggs in one basket, have a dentist on the outside, have my health care with my primary care doctor on the inside at Providence Hospital, and my eye care, that's outside the hospital, someplace else on Capitol Hill. Everything is separate out since all this new entity. And it's a struggle for any family that's struggling below poverty to try to figure out where the best support services is for him or her or their family. It's hard. It's devastating. You
And-
know,
and-
I didn't know I was gonna be going through this. I had
and-
no
and-
idea.
In fact, Miss Juanita, it's especially difficult for seniors. And for seniors, there is what's called dual eligibility. And I know that Dr. Crowder can speak to dual eligibility. That's Medicare and Medicaid together. As I have gone around the city and talked to seniors, one of the questions that I ask is, how many of you know how to navigate your Medicare and Medicaid to get the best out of it for yourself? And I would say only about 5 to 10% can say that they can navigate. 90% of the residents that I have talked to said they cannot navigate it. And so what I think we need is at the very least a senior health ombudsman, where
Yeah,
people can call their
navigate.
office and understand the ombudsman can help them navigate their health care and health challenges, not just health care, but health challenges as well. And that is something that I think that we need. And so, but you're right. Sometimes seniors get notices, they don't understand the notice, why, or they go to their doctor and find out that the insurance has been canceled or changed, and no real reason given. And so to navigate that becomes it's stressful by itself. That's a point of stress for someone not knowing how to navigate their healthcare when they are in need of health services.
So let me add something to that, Juanita, because we're seeing what you're actually speaking of throughout the healthcare system, right? So I think it's important to discuss the fact that that's happening everywhere. So it doesn't matter if it's Medicaid, Medicare, an HMO, a private insurer. They can renegotiate their rates with the physician or the hospitals, and they do not notify the patients, right? So that happens throughout all insurers, right? So we're seeing, so Juanita, what you're saying, and this is why I think it's very important that we actually get to a level set where we just insure everybody. This is what it looks like. This is the foundational plan that will take care of the majority of your health expenses. And then if you want something more, if you want the Cadillac plan, then you can pay more for the Cadillac plan. So let me just say real quickly. So there are, because Social Security, Medicare reimbursement rates are going down, there are primary care physicians that are opting out of Medicare. And they're saying, we are not taking Medicare anymore. So just like what Juanita is saying, and this is why I tell people, this is really all of our problems, because as this system actually devolves, right? Well, it may impact Juanita, but pretty soon it's going to impact all of us, right? And so there are physicians now that are opting out of Medicare. There are physicians that are opting out of, we're not going to take any of your insurance. Here's what we're going to do. We're going to hand you the form. You go fill it out. You go fight with your insurance company, and we want $199 a month, right? They're called subscription programs, right? And so what we're really seeing right now, we are really seeing, I think, the disaggregation of our healthcare system in a way that is really, really unprecedented. And COVID just, made everything hasten faster. But go ahead, you had a question, Joanna.
Well, waiting for you. I think my reaction is, oh shit, we are talking about the extreme of capitalism.
Yeah.
And we need universal care, and we need to change it. Do you feel that Obamacare, that was supposed to, at least have health insurance more accessible across the board, has it helped any?
Yeah, so I can't even imagine. I can't even imagine what COVID would have been like without Obamacare.
Oh my goodness.
I can't even begin to imagine. Okay, so I definitely, Obamacare definitely actually helped. One thing that I think is important is people need to make a distinction. People talk about healthcare reform. We really haven't been doing healthcare reform. We've been doing health insurance reform.
Right.
Yes.
Okay.
Yes.
Okay. Okay. So Obamacare is health insurance reform, right?
Yes.
And it definitely helped. It actually, it got a lot of people, insured that were never insured before. But you have a lot of states, Florida, Texas, you have some big states that have not actually come on board with Obamacare and the Medicaid expansion. And we see the results of it in their COVID numbers, right?
Right.
And so it really, so I think we could go a lot further with it, but ultimately we're going to have to insure everyone. I think DC could actually be a leader by putting in the employer mandate. The employer mandate, there are still companies in Hawaii, they haven't left. There's still companies in Massachusetts, they haven't left with the employer mandate. And I think DC could put in place an employer mandate because we have a very low unemployment rate. So if you put in an employee mandate, and most of these employers are going to have to do it anyhow, because you're not going to be able to track these employees with just higher and higher and higher hourly rates. You're going to have to actually provide a little bit more. And I think we could go a long way and be an example for the country by putting in an employer mandate.
So one of the things in terms of the employer mandate, and I do agree with Dr. Crowder, but since COVID, a lot of people are not really tracking this. The unemployment rate has really blown up. When you look at the unemployment rate just between March and April of 2020, when COVID hit, in most wards, almost all the wards, the unemployment rate almost doubled, and it's still high. So to give you an example, before COVID hit, the unemployment rate in Ward 8 was 12%. When COVID hit the very next month, it went to 20%, 22%. It has climbed to 22, 25% since April of 2020. It's gone down a little bit, but it's still higher than what it was. And that existed for all the wards. It wasn't just Ward 8. Ward 3 almost doubled in their unemployment rate. Ward 7, all of the wards almost doubled, and we have not gone down in any ward to pre-COVID unemployment levels. We have not gone down to pre-COVID levels yet. And so I think that, you know, we have some real issues. People are, right now, evictions are set to go back full force. That's going to have an effect on people's health. That's going to have an effect on people's housing. And that's going to just drain the city even more. So there's a lot that we have to do to try to get back to pre-COVID levels. So, but for someone who is a health advocate, pre-COVID levels still represented high rates of chronic disease, still represented high rates of food deserts, still, you know, so those things were still in existence pre-COVID for African-American communities.
Yeah.
One of you mentioned that I think it's France that has a pretty good system. So there are capitalist countries somewhere on this earth that make it work better.
Yeah.
So we should take a trip, study the systems, and advocate for change, I guess.
So let me tell you,
we are in a mess, you know. It's incredible just to think about all the complexities. Even if there is a decent insurance that I still have to navigate all the mess.
American capitalism has a very particular trait, and it's spelled GREED.
Yeah, well, yeah, that's true. So let me just share with you, because I've gone all over the world and seen healthcare systems, right? And I've seen ones that work, and I've seen ones that don't work. In addition to France, Singapore also has a very, very good healthcare system. And again, they have a base health insurance that you get as a citizen. You know, let's say it's let's say it's the silver plan, right? And then if you want to pay more, you can get the gold plan, right? And if you want to pay even more, you can get the platinum plan, right? And most of their physicians will take you from any level because the reimbursement rate is sufficient enough to actually make it worthwhile for them to actually do business. And the other thing too is you have a very streamlined process for submitting your actual bills, right? So it's very streamlined. Not a lot of back and forth. We argue over bills in healthcare for months. And I know you guys, if you've done it, you've interfaced with the healthcare system at all, you've seen, the whole disorganization of it. And so those are two places where the healthcare system was really great. I've also seen really poor healthcare systems, which actually look more like ours, which is like Philippines and Zimbabwe, right? Where you get as much healthcare as the money you have in your pocket, right? So when it is time for you in the Philippines to go to the operating room, let's say you're going to get your appendix out, your family has to bring, they say, we need a scalpel, we need 10 packs of gauze, we need 5 packs of towels. You get a list. This is what you need for an appendix to be removed. And your family goes around and gets all that stuff, and you don't go to the operating room till they come back with all those things. And when they come back, that's when you go into the operating room, right? So, you also don't get discharged till the bill is paid 100%. Right.
So
right.
there's something else, though, I want to make sure that we are clear on. Your health and your health care and your relationship with your physician really only accounts for 20% of your total health. The other 80% is your built environment. And that is where the policies that have had racist roots, that is where the policies of redlining in terms of housing, policies that determine where investment goes, that is 80% of your health. So if your built environment has certain attributes, then you are more likely to have higher rates of chronic disease, higher stress, all these levels, which contribute to your health that make you have to go to see the doctor in the first place.
Right.
Yeah. Where did
there any other
the
questions?
highways get built? Yeah. Where
Yeah.
do the dumping stations happen? Yeah.
Yeah. Any other questions? I have one last question, and I'm going to wait to see if anybody else have a question. Okay.
There is
Yes,
one.
Linnell. Linnell,
Yes.
you're on mute, Linnell.
Here I am. So I just love hearing all of this. And Valda, good to see you. Very good to see you.
Yeah.
Ambrose, of course. So I hear you talking, and of course I understand it, I believe it. And my field in the military was public health and preventive medicine. And I think that that's an area that we just don't talk about enough. We don't invest in it enough. And it goes to what you're talking about, Ambrose, about the factors that contribute to health and the things that are left out. And it is a preventative, there is a great deal that we can learn from prevention. And I know working in substance use prevention, just the word itself doesn't fully speak to all the areas of prevention, but in healthcare and healthcare equity, there's definitely so much that could be considered with the prevention part of it. And I think that, I'm always astounded when I got into this field and took like my first public health 101, I thought, well, here are all the answers, prevention, right? And then I started to discover how little money in any budget is committed to prevention.
Yeah.
And I had to do a survey of the county of Cape Cod, where I was an official, to get a grant for prevention, public substance use prevention. And out of every dollar spent on the outcomes of addiction, less than 10 cents was spent on prevention. And and I thought, if they don't turn these numbers around, this won't work. And I think the same thing applies here. And I applaud both of you for being so spot on in your evaluation of the situation. And thank you so much.
You're welcome.
Well, I've been saying this lately, and to give you an example of prevention. So, we really have a crime issue in the District of Columbia right now. And I've been saying very, very much lately, if you want a child to learn math, you put him in front of a math teacher. The teacher teaches him math, and then he has to practice math. That is how a person learns math. It doesn't learn because you're sitting at the desk. Someone has to teach you. You have to engage in practice, and that is how you learn math. It's no different when it comes to nonviolence. Why would we think that someone sitting there would learn how to live a life of nonviolence, which is what Dr. King wanted us to live? You have to be taught. So the CDC recommended as a prevention method to ingrain and embed violence prevention curriculums in our schools so that kids are taught nonviolence from an early age. And if you did that, then they will know what nonviolence actually looks like. And so if we're using that, if we use that kind of same methodology when it comes to health, you know, I'm a master trainer in chronic disease management and diabetes management. And we train residents how to manage their chronic disease. But that's still more midstream than it is upstream. You have to get to diet and exercise and eating right early. You know, how do we train our children to enjoy drinking water as opposed to soda? How do you have to do that from an early age. And so when we talk about upstream, when we talk about prevention, you have to go all the way back as far as you can to try to teach these different things.
And let me just say something on prevention. What would the COVID pandemic have looked like if every household was sent 50 or 100 masks? At the beginning of this pandemic, back in, you know, I was running around buying masks and Lysol and stuff for my neighbors and giving it to them. Now they thought I was crazy because nobody knew it was coming. You know, everybody, you know, they hadn't grasped what was actually happening. But we have this whole thing in our culture of sort of individualism. You know, we're gonna figure it. Everybody's gonna figure it out themselves. No, everyone doesn't figure it out themselves. If we had given out just masks, very, very cheap, how much money would we have saved? I mean, it would have been hundreds of millions of dollars.
Yeah, wow. Good point. I want to thank both Ambrose and Dr. Crowder for being here and teaching us. I felt like I've learned a lot more about the broad aspects of this health equity issue, and we didn't get, there's more to be said, and we may want to invite you back. I was interested also for us to think about what's happening in the opioid crisis in our city.
I could talk for an hour on that one.
Yeah. So we may want to do that because it's shocking that we're having this problem.
Right.
So
Okay,
yeah,
really.
thank you again, and thank you everybody for attending. And Joanna, do you want to say anything?
No, I think you mentioned the upcoming programs, and we're working on many things. Watch for the announcements from the village and come back.
All right.
Bring
Thank you
others.
guys for having
Thank
us.
you.
And,
Thank you
much.
very much for attending.
Thank
We
you.
really appreciate
right.
it.
All right.
Thanks.
Thank
Thank you
you.
all. Have a
Bye.
blessed
Bye.
evening.
Bye.
You too.